This section will provide an introduction to the National HIV/AIDS Strategy, as well as HOPWA's influence on the incidence and prevalence of HIV throughout LA County. The National HIV/AIDS Strategy, also referred to as NHAS, provides a blueprint to HIV/AIDS policy for the U.S. The nation's first comprehensive NHAS was released in 2010, and in the subsequent 5 years, people and organizations have joined together around its vision and goals. The strategy has changed the way the American people talk about HIV, prioritize and organize prevention and care services locally, and deliver clinical and non-clinical services that support people living with HIV to remain engaged in care. The goals of NHAS are to reduce new HIV infections, increase access to care and improve health outcomes for people living with HIV, reduce HIV-related disparities and health inequities, and lastly, achieve a more coordinated national response to the HIV epidemic. NHAS states that it is imperative that the conditions in which people live, learn, work, play, and pray facilitate rather than detract from their ability to lead healthy lives. Such conditions include the background prevalence of HIV in sexual and drug networks, as well as housing, education, employment, family, and social support systems. It has become abundantly clear that these social determinants of health are significant factors in the ability to meet the goals of the strategy. Addressing HIV-related co-occurring conditions and challenges meeting basic needs, such as housing, are both vital components to support the comprehensive, coordinated, and patient-centered care for people living with HIV. Among such efforts, NHAS recommends the following actions. 1. To address policies to promote access to housing, other basic needs, and other support services for people living with HIV. And second, scale up effective evidence-based programs that address social determinants of health, including access to housing assistance. The nation's response to HIV must focus on eliminating barriers to care and coordinating public and private resources to address critical gaps, such as those resulting from poverty, homelessness, and unstable housing. The HOPWA program includes 3 primary objectives for people living with HIV or AIDS. The first is to increase housing stability, the second, to reduce risk of homelessness, and lastly, to increase access to care and support. To help us achieve these goals, it's important to have a good understanding of the HIV epidemic at national, state, and city levels, as this will better inform us of where we need to focus our efforts. Now let's take a look at the HIV care continuum for LA County as of 2014. Of 2,033 new HIV diagnoses, only 71% of these individuals were linked to care within a month of initial diagnosis. There was an estimated 48,154 people living with HIV in 2014, and among those living with HIV in LA County, only 59% were achieving optimal results through effective treatment. In other words, they were virally suppressed. Achieving these optimal results requires collaboration across all levels of the treatment cascade, and stable housing can serve as a base for increasing access to and retention in HIV treatment, quality care, and other non-medical supports. Looking at this continuum, you may ask yourself where the role of a housing specialist fits in this continuum. The goal is to see a shift in this continuum where the number of virally suppressed individuals is 100% and the number of new diagnoses is close to, if not zero. As a housing specialist, your role comes between the bars that you see in this graph. Between the bars along this continuum are barriers or challenges that people living with HIV or AIDS may encounter that prevent them from moving along the continuum. One of these barriers or challenges is lack of housing. As we saw in the previous sections, housing is a critical component of HIV care and prevention. Let's take a closer look at the HIV epidemic in terms of how the HIV epidemic is affecting various age groups in LA County. This slide displays the HIV care continuum for LA County represented by age group for 2014. We're looking at individuals between the ages of 18 and older, which have been divided into 3 groups. Those ages 18 to 29 are depicted by the beige bar on the graph, 30 to 49-year-olds are depicted by the purple bar, and people living with HIV older than 50 are represented by the green bar. The number of individuals living with HIV is roughly equally spread among each of these 3 age groups. Moving to the right, we see that people living with HIV who are 50 or older have higher percentages of being engaged, retained, and virally suppressed when compared to their younger counterparts. The age group with the lowest percentages of people engaged, retained, and virally suppressed are those between the ages of 18 to 29. If we take a closer look at where the HIV epidemic is more heavily concentrated, we see that the number of people living with HIV is greatest among individuals between the ages of 30 to 49, which represent a total of 24,348 individuals in LA County. Due to advances in treatment, we are seeing a shift in regards to who is living with HIV. When the epidemic first began, people living with HIV had shorter lifespans, and the chances of them living into old age were very rare. Now we're seeing that people living with HIV are living well into their 80s or longer, therefore causing us to shift how and what services are being offered. There's an ever-evolving need to not just meet the housing needs of our younger population living with HIV, but also take into account the needs of our aging HIV population who may require additional services in regards to housing. We've now looked at the HIV continuum from a broad perspective, narrowed it down by providing a breakdown of the HIV epidemic by age, and now we're going to move on to see how the HIV continuum looks when looking at race and ethnicity. Here we can see the HIV care continuum is broken down into 6 categories. The beige bars represent African Americans, Latinos are represented by the red bar, green is representatives of whites, Asian and Pacific Islanders are represented by the purple bar, the blue is for multiracial, and the orange-colored bars represent American Indian and Native Americans. Among categories of engagement in care, retention in care, and viral suppression, African Americans are demonstrated as having the lowest percentages in comparison to all other races. Taking a closer look at the retained in care bar, we can see that Native Americans, African Americans, and whites have the lowest retention rates in HIV. Stable housing is critical to promoting full engagement in HIV care from diagnosis through retaining a suppressed viral load. Through these mechanisms, stable housing helps contribute to national HIV care and prevention of transmission goals. The 2010-2011 Los Angeles Coordinated HIV Needs Assessment is the 5th survey that the Commission and DHSP have conducted. The survey was designed to elicit quantitative data on service needs, utilization, and gaps for individuals accessing HIV services in the county. Ryan White-funded services focus primarily on medical care. For the purposes of the survey, 47 services were grouped into 4 service clusters: health-related, case management, residential care, housing and transportation, and support services. A total of 450 interviews were conducted with individuals at 49 service sites. 12% out of the 450 total survey respondents were homeless. Of the 10 services for which these individuals reported any need, only 2 were housing related: transitional housing and housing case management. As you can see in the table, 51.9% of the homeless respondents reported needing housing case management. 1/3, which equals to 38.4% of survey respondents, reported having a mental health issue. Rental assistance was ranked 9th for the top needed service, with 59% of respondents with mental health issues. In addition to service needs and gaps, the Los Angeles Coordinated HIV Needs Assessment Survey also collected information on respondents' awareness of the 47 services. The survey results indicated that homeless respondents were 3.7 times more likely to report a service gap compared to housed respondents. Although it is surprising that housing was not more commonly cited as a needed service among these various subpopulations, rental assistance' consistent top ranking as a service gap illustrates its critical need. We've talked about homelessness in these last 2 slides, and even though not all people living with HIV are necessarily homeless, it's important to take a closer look at how exactly we may define homelessness and the factors that put people at risk for homelessness. From an ecological perspective, homelessness can be understood as a result of interactions among risk factors ranging from individual conditions to socioeconomic structures and environmental circumstances. Homelessness manifests itself on a temporal continuum as situational, episodic, or chronic. Over time, homeless individuals may experience changes in housing status that include being on the street, shared dwelling, emergency shelter, transitional housing, and permanent housing. This also includes hospitalization and incarceration in correctional facilities. Episodes of homelessness result in individual and social consequences, which are commonly detrimental to individual well-being and negatively affect social interactions within the community. Roger M. Newey and David A. Patterson propose a broad conceptual model of homelessness that examines biopsychosocial risk factors associated with homelessness in relation to the constructs of temporal course, housing status, and individual and social outcomes. They employ an ecological perspective to situate and describe known biopsychosocial risk factors in a hierarchy of systems and domains. The goal is to transcend the classic debate that posited homelessness as a result of either individual or structural factors. Homelessness cannot be understood or addressed by focusing solely on causal factors and ignoring its various temporal dimensions, the spectrum of consequential individual and social outcomes, and the resulting limited housing options associated with homelessness. To view homelessness only from the perspective of why and how families and individuals became homeless is to see only half the picture. This conceptual model is intended to articulate a just thought of homelessness, not only recognizing the constituent parts of the phenomenon, but also offering a map of the dynamic interactions of the elements of the model. We'll take a closer look at the ecological model of homelessness during the face-to-face workshop. This concludes Section 2 of Module 1. Before moving on to Section 3, take the time to complete the corresponding activity.